الو السلام عليكم. دكتورة مي، دكتورة هبة.
وعليكم السلام.
كيف الحال
عليكم
دكتورة؟
السلام ورحمة الله وبركاته.
كيف الصحة بشينا عنكم؟
الله
هلا
يخليك.
حياك الله.
الله يعطيكم العافية على الحضور والتقييم اللي أكثر من رائع. طيب دكتور روان موجودة؟
موجودة.
طيب let's start the second session. Thank you for rejoining us, and we would like to start this session with the first presentation by Dr. Rawan, entitled Micro-RNR Loaded Schistome Nanoparticles for the Treatment of Glioblastoma. So Dr. Rawan, you can start now.
يعطيك العافية دكتور.
Let's give a brief introduction about the judges. I would like to introduce our judge panel. Each judge has been selected due to their integrity, experience, and depth in knowledge. We have Dr. May Al-Ajaji. Dr. May is an assistant professor of pharmacology and toxicology in King Saud bin Abdulaziz University. Dr. Al-Ajaji earned her PhD degree from Virginia University. She also had a master's degree in medical education from King Saud bin Abdulaziz University. Dr. May holds many positions in College of Pharmacy in relation to quality and accreditation. In addition, she is involved in research and acts as voting member in the IRB committee. Also, we have Dr. Heba Dosri. Dr. Heba is a professor of pharmaceutics. Since Dr. Heba received her PhD in pharmacy, she has been an active researcher with more than 55 published papers in distinguished peer-reviewed journals. She received many national and international awards in the recognition of her outstanding research work. Dr. Heba is also a member in many international scientific organizations. Okay, Dr. Rawan, can we start now?
إن شاء الله. يعطيك العافية. واضحة سلايد للجميع؟
واضحة.
طيب، بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته. صباح الخير على الجميع. This is Rawan Swalem, postgraduate at Pharmaceutics Department, College of Pharmacy, King Saud University. I have worked on a research that developed chitosan nanoparticles loaded with microRNA for treatment of glioblastoma. Today I'm going to present an abstract of my thesis, starting from a general introduction of glioblastoma and ending with sharing final conclusions. So let's get started. Firstly, what is glioblastoma? Glioblastoma represents the most common and aggressive form of primary brain tumor in adults. Despite current treatment options, glioblastoma remains associated with significant neurological morbidities, which urge the need for new therapeutics, such as microRNA, to improve patients' outcomes. Recent evidence have implicated microRNA 219 specifically in regulation of genes contributed in glioblastoma pathogenesis, including cell proliferation, invasion, and angiogenesis genes. The defined mechanism of action, mainly by targeting MIR219 targeting the messenger RNA of epidermal growth factor receptor, ROBO1 and SAL4 proteins. Thus, this study aimed to formulate MIR219 in chitosan nanoparticles, characterize them, and investigate their efficacy on human glioma cell line U87. For the methods, nanoparticles were prepared using ionic gelation method. Low molecular weight of chitosan was dissolved in acetic acid. Then microRNA was pre-incubated with TPP, which is a cross-linker. Then this mixture was added dropwise to the chitosan solution. After stirring for 1 hour and incubation time, nanoparticles were collected by ultracentrifugation, lyophilized for further use. After nanoparticle production, physicochemical properties of the nanoparticles were characterized, including particle size, PDI, zeta potential, encapsulation efficiency, and in vitro release profile of the drug. In addition, The influence of critical process parameters of nanoparticles were investigated, including chitosan concentration, its pH, the ratio of chitosan to TPP concentration, and the ratio of nanoparticles to the amount of loaded drug. Apoptotic effect of MER219 was examined on human glioma cell line U87 by Presto Blue reagent according to manufacturer instructions. Statistical analysis was performed using PRISM 8, taking p-value less than 0.05 as a significance threshold. Alhamdulillah, we succeed to get the smallest particle size of 109 nanometer in a homogeneous formulation with PDI equal to 0.2 after optimization process. The overall surface charge of the nanoparticles was positive charge equal to 20.5 millivolt. Encapsulation efficiency of MER219 in the loaded nanoparticles has reached 95%. The nanoparticles loaded with MER219 has reduced cell survival of U87 cells into 67.5% after 48 hours of post-transcription. Morphology of nanoparticles were visualized under transmission electron microscopy. Both empty and MER219 loaded nanoparticles showed spherical shapes. We can see here, obviously, the gene loaded inside the nanoparticles. Successfully, gel retardation assay has confirmed the integrity of MER219 after production process. You can see MER219 retarded in lane 3, while lane 2 was loaded with naked microRNA as a control. In vitro release study demonstrate sustained release of MER219 from the chitosan nanoparticles, which is a characteristic feature of chitosan-based nanoparticles. At that stage, cell proliferation experiment was performed. All 3 doses of MER219 had reduced cell survival, showing the highest apoptotic effect with 10 picomoles, in where cell survival was reduced into 78% after 24 hours of post-transcription when compared to the control. The cells were also treated with MER219 transfected using GenMute transfection reagent, which is a commercial available transfection reagent. Satisfyingly, the generated nanoparticles showed a comparable effect to the commercial transfection reagent. Moreover, another experiment was run for 48 hours of post-transfection using a dose of 10 picomoles. The results showed a further reduction on the percentage of cell viability into 67.5%. Furthermore, and to demonstrate the safety and specificity of nanoparticles to the normal cells, fibroblast cells were treated by the generated nanoparticles. Fibroblast cells' viability has not diminished after treatment with MER219 through both nanoparticles and transfection reagent, indicating its specificity to the cancerous cells. As a conclusion, the optimized formulation was at minimum particle size, positive surface charge, maximum encapsulation efficiency, sustained in vitro release, stable gene after production process, and a favorable apoptotic effect on glioma cell line. Subsequently, the generated nanoparticles provide a novel delivery system for MER219 and has a potential for glioblastoma treatment. Lastly, you can find all the related references uploaded through the displayed barcode. Questions?
يعطيك العافية روان، شكرا جزيلا.
الله
بس
يعافيك.
ودي couple of questions.
تفضل.
ايش type of media اللي انت استخدمتيها عشان perform ال in vitro release study.
أنا استخدمت TE buffer. ال pH كان adjusted to 7.4 to simulate the biological system.
Okay. انت كاتبه انك في ال statistical analysis you used PRISM
أيوة.
as a software. طيب ايش الكاين تبع ال statistical test to assess اللي هي ال influence of the formulation parameters نفسها عشان تحددي which one has an impact على ال physicochemical properties تبعت ال prepared nanoparticles حقتك؟
كنت غالبا أعتمد على ال one way ANOVA test followed by 2 key إذا كنت أحتاجه. أيوة.
اوكي ثانك يو روان، شكرا لك.
يعطيك العافية دكتورة.
Rawan, thank you so much for your presentation, and I agree with you. Nanoparticles based drug delivery could change the way we treat many diseases. At the conclusion slide, you mentioned that you said potential in treating glioblastoma. Can you elaborate more compared to the many clinical or many experimental drug therapy in the clinical trial now?
ممتاز. At clinical trial stage, I'm not really involved in clinical trial stage, but at research stage, if it is right to say that, it is found that MER219 is downregulated in glioblastoma tissue when compared to the normal glioma tissue, normal brain tissue. الريسيرشر حاولوا انهم يتعرفون على سبب لهذا الريدكشن. وجدوا ان من الاشياء اللي كانت لها علاقه هو elevation لل other messenger RNA أو expression of other proteins اللي لها involved في glioblastoma pathogenesis مثل الإبيديرمال growth factor receptor وله impact على cell proliferation و cell invasion. كمان السالفور والروبو 1 proteins ولها effect و involved in pathogenesis of glioblastoma. فبهذه الطريقة وبالإضافة إلى bioinformatic analysis to define a target of the MER219 to messenger RNA of such proteins. فلما وجدوا هذه العلاقة أصبح يعني استخلصنا أو استنتجنا إنه ال MER219 as a candidate لما أسوي له ectopic expression delivery للغلايوما patients هو يعتبر candidate في إنه يدخل في التريتمنت.
Thank you روان، الله يعطيك العافية. No more question.
يعطيك العافية دكتور.
Thank you, Dr. Rawan, for your great presentation, and I hopefully it will have a good impact in practice. Next, we'll go for the next researcher, Dr. Rafal Ghatani, for the research entitled Prescribing Pattern of Fosfomycin in Gram-negative urinary tract infection at Tertiary Care Hospital. Dr. Rahaf, are you there?
Yes.
So we can start now.
Can you see my slides?
No.
Now can you see my slides?
Yes.
Perfect. So, good afternoon everyone. This is Rafal Ghatani, actual pharmacy resident in King Abdulaziz Medical City in Riyadh. So, our research title, as Dr. Khalid said, prescribing pattern of fosfomycin in gram-negative urinary tract infection at Tertiary Care Hospital. So, listed here, I have my team members who helped me out on this research. So, as a start, urinary tract infections are known as some of the most common infections reported in hospitals. And UTI can be either uncomplicated or complicated, depend on several factors. And these UTIs are caused by gram-negative organisms known as enterobacteriaceae.
So these type of pathogens are capable for producing extended spectrum beta-lactamase, the ESBL. So which is considered as an issue with treating the UTI over the world. So it has been reported that UTI result in more hospital admission and longer stay. And managing these UTIs in those patients is considered tougher since most of these patients has many comorbidities, polypharmacies, advanced age, allergies, or resistance pattern toward the first-line medications. So looking to alternative agents was needed. So fosfomycin is considered one of these agents, and it's indicated for the treatment of UTI caused by gram-negative bacteria. And an important characteristics of the fosfomycin, it's broad spectrum activity, including the ESBL, as we mentioned. Also, it makes an excellent option against the multi-resistant strains. So there has been conflicting data regarding the efficacy of fosfomycin on bacterial response as compared to the first line agents. So there are only few reports have been published regarding the fosfomycin use in UTI. And since there is a limited data published regarding the clinical use of fosfomycin, our aim of this study was to describe the dosing pattern of fosfomycin in outpatient and inpatient with UTI. So for the methodology, we conducted a retrospective short review study in King Abdulaziz Medical City, National Guard Health Affairs in Riyadh. We included all patients who diagnosed with UTI and received fosfomycin from January 2016 to December 2019, and as a treatment or prophylaxis, and either as an outpatient or inpatient setting. However, we excluded patients who received other antibiotic other than the fosfomycin. Also, any patient has any allergies from fosfomycin, or patient with no follow-up after receiving the medication. So we used a convenient sampling technique and including all the eligible patients. And we started collecting the data by reviewing the medical chart of the patients in the VIS care system used in King Abdulaziz Medical City. So here in the result, first we will start with the demographic data. So here you can see that a total of 35 patients included in the study. 72% of them were women. Also, out of the included patients, 9 of them were kidney transplant recipient, while the majority of them were diabetic patients, 72%. Also, 37.14 received the fosfomycin as a treatment, while the majority received it as a once weekly prophylactic dose. For the type of UTI, the majority had cystitis with a 69%. Okay. Here you can see that 60% of the patient took fosfomycin as an inpatient. However, a lot of the patients took the first dose or two first doses in the inpatient setting. Then they were discharged home as we have the fosfomycin as an oral dosage form in the KMC. And here you can see that the isolated microorganisms that our included patient had. And the most common causative bug were Klebsiella pneumoniae and E. coli, which account for 37.5 each. For the recurrent UTI, so we have for the recurrent UTI divided to 3, either no or there is no recurrent, or a reinfection, or a relapse. So we define the relapse as if there is a recurrence occurred within the 2 weeks of completion of the treatment from the original infection. So the infection, the organism should be the same. However, when the recurrent UTI occurred more than 2 weeks after the treatment, we consider it a reinfection. Even the reinfection, even the infection, the infecting organism was the same. So it shows here it was 86% of the patient has reinfected UTI. In this figure, you can see we also assessed the patient microbiological and clinical response. So for the microbiological response, we define it as either cure or failure, depend on the urine culture, if it's less than 140 of the pathogen, or if it's 140 or more, we consider it a failure. And it shows here 80% of them were acute. However, only 20% of them had failed the treatment, and the most common organism in the failure patient who had failed the microbiological response was Klebsiella pneumoniae. For the clinical response, which was an indicator for therapeutic effect of fosfomycin, was defined as either cure, improvement, or failure. And we define it as cure if there is any elimination of all the symptoms, improvement if there is most but not all the symptoms improved or absent of the symptoms, failure if there was no improvement from the initial assessment. So it shows that only 12.5% of those patients were cured. So in conclusion, fosfomycin use shows significant microbiological efficacy with a lower clinical response with UTI. Although the sample size, lack of MIC data, it was not provided by the lab, and being retrospective are considerable limitation of our study. However, it's urged they need to work on prescribing guidelines and further study to review its use and optimal duration in complicated UTI infections. And thank you so much. That's all. Any questions?
يعطيك العافية رهف، شكرا لك. يمكن أنا هبدأ من حيث ما انتهيتي أنت في الكونكلوجن. You said إنه بالليميتيشن السامبل سايز I was surprised برضه إني شفتهم 35 patients. And it's only you collected data من King Abdulaziz Medical City, right?
So it's really it was hard because in the beginning it was the fosfomycin was non-formulary, so there was a lot of restrictions. So it's just been approved to be in the formulary, added to the formulary from maybe 3 or the beginning of 2020. So it's before we collected the data before.
You mean it was added to the formulary in 2020? So it was only prescribed in King Abdulaziz Medical City?
No. We the study done only in this in one center study. So it's only done in King Abdulaziz Medical City, and it was non-formulary until the beginning of 2020. It's added to the formulary. So I think that's
the research right now. Would you like to go further and collect more samples, like adjust the sample size or collect it from other hospitals?
Yes, actually, we tried to see the number of patients who received fosfomycin for this year, for 2020. It wasn't that big number, but I think we will see different centers. Maybe we can include the different centers.
Okay, thank you, Rahaf. Shukran.
Rahaf, thank you so much. I agree with Dr. Hiba. I have the same concern with the sample size. My question to you, can you elaborate more on next? What is your next step now? You mentioned it might change the guideline. Can you elaborate more in this area?
So we see the dosing patterns of the fosfomycin, and it's really surprised us to see different dosing of fosfomycin, because we know it's only had approved the 3 gram once dose. So 1 dose. So we see different dosing like 1.5 and 1 gram, and it's really surprising because we didn't see it before. So there is only one guideline. It's that mentioned the dosing. Other than this, we don't have a protocol to follow in the dosing of fosfomycin. So I think we need further studies and also prescribing guidelines for fosfomycin.
Thank you, Rahaf, so much. No more questions from my side.
Thank you, Dr. Lee.
Yes, same here. Thank you. No further question.
Thank you so much.
يعطيكم العافية. Thank you, Dr. Rahaf, for your great presentation. Now the second researchers is Dr. Saja Al-Habardi for research entitled Lonazepam and the potential risk for somnambulism. Dr. Saja, are you there? Dr. Saja? أتوقع ما موجود. So we'll move for the next researchers, Dr. Afaf Dihesh, for the research entitled Calcitonin-induced stem cell-like phenotype in prostate cancer cells. Dr. Afaf?
Yes, I'm here.
Okay, you can start now.
Okay. Thank you so much. Assalamu alaikum. And sorry. Just 1 minute to just upload my. Can you see my presentation?
Yes, but display it as full screen. It's okay now.
It's okay?
Yes.
Okay. Assalamu alaikum. This is Rafal Ghatani, assistant professor at King.
Can you reload it, Dr. Afaf?
Reloading.
Dr. Afaf?
Yes. Is it
Can
okay?
Now it's okay. No problem.
Is it okay?
Yes.
So can I start? Can see my presentation?
Yes, yes.
Okay.
You can start now. You can start now.
Okay, thank you. Assalamu alaikum. I'm so glad to be part in the first Pharmacy Research Day, and I will talk about my project, calcitonin-induced stem cell-like phenotype in prostate cancer cells. So, okay, so in prostate cancers, we have two different types. We have androgen dependent, where the prostate cancer cells grow very slowly and confined only in the prostate gland, while the androgen independent type, the cell here more aggressive and can spread very quickly. So androgen ablation therapy is the first line treatment for prostate cancer, and it works for some time. However, the disease sometimes progresses to androgen independent stage, and during this stage, it will increase the morbidity and mortality with patient, especially for the metastatic disease. So cancer metastasis is a complex multi-step process which involves increase the tumor cell proliferation, and the cells start to lose their adhesion and start to migrate to the nearest tissue invasion, and also build up a new blood vessels through angiogenesis, and finally cell implementation in distant organ. So the activation of epithelial mesenchymal transition have been proposed as essential step for tumor dissemination and cancer progression. So what is EMT? EMT is a multiple step process which allow the normal epithelial cell to undergo some changes and acquire the mesenchymal cell phenotype, which lead to the cells acquire more aggressive traits and invasiveness phenotype, which lead to a tumor recurrence and metastasis. As you can see here, this is the epithelial phenotype, and this is the AMT once the cell undergo the transition. So epithelium-mesenchymal transition generates cells with properties of cancer stem-like cells. So during AMT process, the de-attachment cells usually acquire or need some characteristics like self-renewal capability to build a secondary tumor, and this capability or these characteristics are exhibited in the stem cell in stem-like cells. So epithelium-mesenchymal transition as well as cancer stem cell features increase during the androgen deprivation stage, and during this stage the prostate cancer cells secreted some neuroendocrine peptides like pompocin, neurotensin, and calcitonin. So we'll focus about the calcitonin. Calcitonin and calcitonin receptors expression in prostate cancer, and after extensive studies in our laboratory, we found that the CT-CTR expression increased remarkably in the advanced prostate cancer, and also it has an important role to induce the tumorigenicity, invasiveness, and metastasis. After that, we studied the pathway of calcitonin and its receptor, and we found that upon activation of CT-CTR lead to activation of PKA-ACAP2 pathway, then lead to phosphorylation of ZO1. This phosphorylation will lead to loss of cell-cell junction and loss of epithelial integrity and polarity, ultimately lead to tumor metastasis. After that, we dig in more in the pathway of CTR, and we found that the cytoplasmic C-tail of calcitonin receptor associated with the tight junction ZO1, and this interaction of the C or the carboxy terminus of CTR and the BDZ3 domain in the ZO1 is very critical and important for formation of distant metastasis. After that, we asked ourselves, does active CT-CTR autocrine axis increases cancer stem cell in prostate cancer? So to validate this hypothesis, we used 3 different cell lines. We used PC3, where it's expressed calcitonin but not calcitonin receptor. Then from this cell line, we transfected PC3 and become expressed CTR, and we call it PC3 CTR, which express both calcitonin and calcitonin receptor. Then we mutated this cell line by deleting the last 3 amino acid and replace it with alanine in the C terminal of calcitonin receptor, and we call it PC3 CTR delta ESS. Excuse me. After that, we fractionated the prostate cells into fast, slow, and non-adherent, depending on their ability to adhere to the collagen within 5 minutes, 20 minutes, or longer. So basically, the cells were seeded on collagen-coated plate for 5 minutes, and then the cells that adhere were used as fast adherent. Then the cells that did not attach here harvested and reseeded in a new collagen-coated plate for 20 minutes, and we call it this fraction slow adherent. And the cells that did not adhere here replated in new collagen-coated plate, and we call it non-adherent. And here we can see the result. Only 20% of the cells in the BC3 had the fast adherent, while the percentage jumped to the 80% of the BC3 CTR delta wild type, and here for the mutant CTR decreased to the 50%. So the result here suggests that the prostate cancer cell with active CT-CTR axis robustly adhere to the collagen-coated plate compared to the inactive BC3 cells, or the mutant CT-CTR, which is the CTR delta ESS, Also, the fast adherent CTR wild type are enriched with cancer stem cells. After that, we again fractionated the cells, as mentioned before, and the cells were labeled with CD44, CD133, and alpha-2 beta-1 integrin as stem cell antigen markers using flow cytometry experiment. And here we want to examine the effect of CTR wild type and the CTR delta ESS on their expression of stem cell antigen. And here the result showing that the BC3 express really low percentage in the CD44 and CD133 by 1.6 and 0.8 only, while the percentage increase in the CTR wild type jumped to 34.5 and 38 respectively, and then decrease in the mutant CTR to 14 and 17. So these results confirm that the mutant CTR delta ESS was much less potent in increasing expression of stem cell antigen markers of cancer stem cell-like cell population as compared to the CTR wild type. And then here the result for alpha-2 beta-1 positive cells, we can see all the cell lines express high percentage of this cancer stem cell, and the result was not surprised since the alpha-2 beta-1 increased and upregulated in all prostate cancer cells, and the modulation of calcitonin receptor will not change its expression. Next, we examine whether the CTR wild type and CTR delta ESS have the influence on their metastasis capacity in nude mice. And here you can see the H&E histology and prostate stem cell antigen immunofluorescence showed that the tissue was completely taken over by the tumor cells and lost completely the normal morphology for both fast and slow adherent in the BC3 CTR wild type. While here in the CTR delta ESS express the normal or display the normal morphology for both subfraction. And here you can see the prostate weight at necropathy for BC3 cell line, BC3 CTR wild type, BC3 CTR delta ESS. And here we can see the prostate that's receiving the CTR wild type fast adherent has the largest tumor weight compared to that with the mutant delta ESS. Next, we examined the distant metastasis, and we found that the fast adherent cells expressing CTR wild type were more aggressive in forming this distant metastasis, and the most favored target organ were kidneys, femur, brain, and lungs, compared to the normal morphology for the CTR delta ESS for all the organs. And the result here further confirmed by prostate stem cell antigen immunofluorescence for the CTR wild type fast and slow and CTR delta ESS fast and slow. Here you can see the area percentage of micrometastasis, and we can see the significant differences in the metastasis for the CTR wild type compared to the mutant CTR for all organs, lungs, kidney, femur, and brain. So in conclusion, the calcitonin receptor play a crucial role in cancer stem cell in prostate cancer. Also, the activation of calcitonin receptor axis increase the overall stemness of prostate BC3 cell lines. Also, the mutation in the CTR cytoplasmic tail only by deletion last 3 amino acids will completely abrogate the tumor formation and metastatic potential. Thank you all for listening, and questions more than welcome.
يعطيك العافية دكتورة عفاف. Thank you very much. I'm really connected to the presentation of any of the basic pharmaceutical sciences, pharmacology especially.
Thank you.
Thank you. So I would love to ask 2 questions. Why did you choose this kind of strains of mice and not rat to perform the study?
Okay, so here in the study we use the node mice because usually develop the tumor very fast. So within like 15 days, the tumor developed in the PC3 CTR wild type, and 30 days for the PC3 cells. So we use this type of tumor to this type of mice to develop the tumor very fast.
Why not this strain of mice and not a rat? I saw in your abstract that you did some tissue graft.
Yes.
Yes, this is why the nude mice, they have this, you know, the mutation, the genetic mutation. So they they have this genetic mutation so that it wouldn't reject the graft, because you perform a tissue graft in your research, right?
Right. Yes, that's right.
Yes. Yes. Another question, please, about the known target. Any other known target for CT and CTR, please?
Other targets?
Yes. Than calcitonin.
You mean other target tumor?
No. I mean, you know that the calcitonin is the substrate?
Yeah.
Yes. Okay. Did you try any other drugs that it may cause interaction with the signals or no?
Well, in our laboratory, we use calcitonin and its receptor for all development of the cancer, prostate cancer. So we didn't focus in the other pathway. So we only focused on the calcitonin and its receptor and the manipulation of the calcitonin receptor, as I mentioned in the presentation. So we only delete the last 3 amino acids and the metastasis completely abrogated or abolished.
No further question for me.
شكرا.
دكتورة عفاف الله يعطيك العافية وما شاء الله دكتورة هبة غطيت كل حاجة. I just will follow up. The mice study done here or in the US?
No, in the US.
In the US. Is there any plan to establish خلينا نقول a pipeline؟ لأنه الstudy is amazing. I would love يعني to know إنه عندنا potential to conduct that type of study here in Saudi Arabia. Is there a plan?
Yes, I'm so happy to plan with other researchers related to this, especially the neuroendocrine tumor, which increased the calcitonin, especially lung cancer, colon cancer, thyroid cancer. So, yeah.
Okay. Thank you so much, Doctora. No further question.
Thank you so much.
Yes, thank you.
يعطيكم العافية. Thank you, Dr. Afaf, for your great presentation. We'll go for the next researchers, Dr. Ghada Merdouawi, with research entitled Adverse Drug Reaction Spontaneously Reported at a Tertiary Care Hospital and Preventable Measure Implemented. Dr. Ghada?
Yes. Can you see my slides?
Yes, you can start.
Hold on, let me just share it. بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته جميعا. I would like first to thank the organizing committee for accepting our research to be presented today on the first Pharmacy Research Day. My outline for the research, I will go through the background, objectives, methods, results, then I will conclude with the take-home messages for our research. Starting with the background, adverse drug reaction are a concern in the pharmacotherapeutic approach in treating a disease and a burden that may alter the benefit-risk balance. There were some limitations of clinical trials that we have a problem with statistical facts due to limited sample size. Adverse drug reaction are underreporting, and we only see the tip of the iceberg. Most clinical trial designs have strict inclusion criteria. Some of them they are excluding the comorbid diseases, and some of them they are excluding some population like pregnancy. Many countries published their spontaneous adverse drug reaction to inform the medical society about the prevalence and rate, and other studies have explored the economic burden and consequences of adverse drug reaction on the healthcare systems. Our objectives for the study is to characterize and describe adverse drug reaction reports with respect of reporting rate, patient characteristics, suspected drug involved, classes of drugs, seriousness, outcome, reporting specialties, and also to elaborate on measures have been taken whenever adverse drug reactions reported. We had approval from the Institutional Research Ethics Board for our research. It's a retrospective analysis for all adverse drug reaction reports submitted through our hospital reporting system, safety reporting system, from January 2016 to December 2019. Our setting, it's only the Ministry of National Guard Central Region. We look at the data and we analyze the data from different angles. We look at the data from the drug classes. We utilize the therapeutic group cluster categorized by American Association of Poison Control Centers. And we look at the data from the system organ class by the Medical Dictionary for Regulatory Activities, MedDRA. Also, we look at the data from the outcome, and we utilize the Hartwig's severity assessment, which is divided into 7 types. And the last but not the least, the causality assessment by utilizing the Naringio scoring tool, which is divided into 4: definite, probable, possible, and doubtful. As I mentioned, it's a descriptive statistic. We use this as software package 9.4, and for the classes associated with system organ class, we use the chi-square test with a significant threshold of having 0.05. Now, let's go to the main journey of adverse drug reaction, which is the results. The main core of this study is results. As you can see, there were improving in reporting adverse drug reaction. We have a total of 1,156 adverse drug reaction reported through the 4 years from 2016 till 2019. And you can see a good improvement in reporting during 2018 and 2019. And this is due to the campaign conducted, lectures and meetings conducted with other healthcare specialties, in addition to incentives and appreciations given to the healthcare provider who was involved in reporting adverse drug reaction or helping in adverse drug reaction analysis. If you look at the data from the demographic, you can see the ratio between male and female 3:4, and the highest reported events were for adult patients, although most of the studies have shown that higher incidence of adverse drug reaction happen in elderly and pediatric patients. If we illustrate the adverse drug reaction by the drug class, you can see 27 drug classes with 200 drugs herbs involved. The highest reported were antimicrobial drugs, 56%, followed by analgesics, 11.4%, and the third top were diagnostic agents, 5.1%. We can recognize that 50% of these drugs were having less than 10 reports over the 4 years. Going to the other way of analysis the data by utilizing the system organ class. Out of 27 MedDRA system organ classes, we had 15 reported classes or involved. The highest and the top were immune system disorder. It went with 84% of incidents, and the least or the lower incidents were with the respiratory, psychiatric, and pregnancy-related adverse drug reaction. As I mentioned, the highest were immune system disorder, which had around 85%. The rest of all system-related had 15.2%. If we dig further for the immune-related reactions, you can see the highest were analgesics, with the morphine was the highest reported drug, and the second top reported antimicrobials with drugs involved. Ceftriaxone was the the top reported, followed by piperacillin, tazobactam, and then vancomycin. Now let's move to look at the data from the Hartwig's classification. We had the highest considered or classified as level 3, 88.6%, and we had one incident death related to adverse drug reaction, which is classified as level 7. Looking at the data from the causality assessment, as you can see, the highest were the probable 61%, and for the ADR avoidability assessment, we utilized the Liverpool Adverse Drug Reaction Avoidability Assessment tool, and you can see here 1/3 of reported events considered as definitely avoidable and or possibly avoidable. Who is the highest reporter for adverse drug reaction in our institution central region? We figure out that the highest reporter were nurses with 87.6%, and the second reporter pharmacist profession with a percentage of 11. If we dig further to the data and we look at the data further, we find out that immunological reaction was the most nurses, most reports comes from the nurses were immunological reaction, while the pharmacist non-immunological reaction. There were a tremendous number of initiatives, works have been done to improve, prevent, to take actions based on the reported adverse drug reaction. But here in this presentation, because of the time, I'm going to give an example for each initiative or each class. For example, for drug guidelines, safety alerts, material developed, we have developed the anti-epileptic cross-allergy algorithm, which is posted in one-stop resources. And activities to improve reporting, we did 2 campaigns, and we will have on 2021 another campaign. We awards people, top reporting unit, top reporters, the one who's supporting adverse drug reaction, we give incentives. As a general activities, we have a quarterly educational report. It is assured with the medication safety program meeting in the PNT committee also meeting to take actions, and this is posted also in one-stop resource, and as far as I know also in the pharmacy icon in the internet. Formulary changes, tropicamide 0.5% minimums added to the formulary. And this has happened when a premature baby developed bradycardia cyanosis and desaturated while using the 1% tropicamide. We had a lot of changes, multiple enhancement to our health electronic system to improve allergy documentation field. Some of them implemented already, some of them still on process for implementation. We also shared some rare case reports such as ketamine and psychosis through the one-stop resources, through the meetings, and also with Saudi FDA. So as a conclusion and take-home messages, underreporting remains the main challenge for adverse drug reaction. We only see the tip of the iceberg. We're sure that there are a lot of adverse drug reaction not reported. Campaigns, educational increases reporting of adverse drug reaction, and this is clearly happen or clear in our data. Rare cases such as malignancy reproductive system not reported, and it is ready to be reported also in other studies. 1/3 of our reportable adverse drug reaction considered as avoidable, possibly avoidable, and this is a driver to continue pharmacovigilance activities in our hospital. Monitoring spontaneous adverse drug reaction, it's an easy, convenient, inexpensive to see overall adverse drug reaction reports. Here are some references for our research, and here our research published in Clinical Pharmacy and Therapeutic Journal. And then thank you very much again, and welcome for any question. Hello?
Yes. Dr. Hiba, do you want to start? Okay. A couple of questions. Thank you, Dr. Ghada, for this presentation. In your conclusion, you mentioned underreporting, and I agree it's one of the main challenge. I found it to be difficult to believe that only 1,000, what was the number of the report? 1,000?
Yeah, 1,100 plus.
Is it cover Riyadh, Jeddah, Al Hassa, or just Riyadh?
No, unfortunately, it's only central region.
Central region, okay. My question, is there any plan for using artificial intelligence, machine learning to predict, use this data to predict future adverse drug reaction?
What we are doing now, Doctor, we are collecting the adverse drug reaction that is reported through the hospital health electronic, which is a health best care system. We are grabbing the data which is reported there but not reporting in this safety reporting system, because you know sometimes the challenges with SRS or reporting system is the time consuming, access, network. So what we are doing as an ADR team, we are trying to extrapolate the data of reporting adverse drug reaction in that system, not waiting for persons or healthcare professionals to report it.
Excellent. Can you tell us more about the anti-epileptic cross algorithm initiative?
Yes, we had multiple reactions with the anti-epileptic drugs. It was raised to adverse drug reaction through some safety reporting system. I mean, some reports. So we, like for example, there was a case in pediatric population in Cash. He had a known allergic reaction documented in the system, and then the resident looked at the data and look at the documentation. So she reviewed the file without communicate properly with her consultant. So what happened? She deflagged the patient and she gave her this anti-seizure medication. Patient went with seizures, and they tried to manage the patient. This is one of the cases of deflagging. I think if I'm not mistaken, within this 4 years we had 2 cases like that. So we decided to have same like allergy of beta-lactam, sulfonamide, which is a long time posted in the one-stop resource, to have this algorithm of cross-reactivity with anti-seizure. It was done, alhamdulillah, approved by PNT, and it was posted in one-stop resource. And also office services have been distributed about this initiative.
Thank you, Dr. Ghada. I appreciate that. Dr. Hiba?
Welcome.
Okay, thank you so much for your presentation. Next we have
Welcome.
نشوف مين next عندنا. Next we have دكتورة مرام الزهراني.
أيوة، أهلا. السلام عليكم.
Can you share عليكم السلام. Can you share your presentation with us?
Yes.
الو دكتور سجا.
دكتور معانا الحين دكتورة مرام. دكتورة سجا صارت موجودة؟
اي موجودة هي دكتور. بنبدأ الدكتورة سجا أفضل، بعدين نروح دكتورة مرام.
ما هو مشكلة، تفضل. لا ممتاز، الله يعطيك العافية.
الله يعطيكم العافية. دكتورة سجا.
أيوة موجودة.
أهلا. So the next researcher is Dr. Saja Al-Habardi with research entitled Olanazepam and Potential Risk of Somnambulism. So you can start, Dr. Saja. Can you share your slides? So you can start, Dr. Saja.
Okay. You can see my slide.
Yes.
Okay, good. Good day. I'm Sajjal Habardi. Today I will present olanzapine and potential risk of somnambulism. It's a safety review on behalf of my colleagues at SFDA. So olanzapine is a second-generation antipsychotic that is registered in SFDA in 2014 for the treatment of schizophrenia and bipolar. So the objective of this review is to evaluate the potential risk of somnambulism with olanzapine use, as we detected during our pharmacovigilance activity through screening the WHO database, which called VigiBase, by using VigiTool. So we did a comprehensive literature search by using the available database, such as PubMed and clinical trials and Google Scholar and EDIS. Then we include all the published article in English language from the inception to April 2020. And the result we assessed by using the Bradford Health criteria for assess the causality. Bradford Health criteria, it's an epidemiological tool that is used to assess the causality between the causative agent and the event. And this is the keyword that we used during our search. So as a result, we retrieved more than 100 articles, and among them 109 articles were excluded because it's not met our objective, or duplicate article, or review article, or article with no adverse event of interest. So we end up with 8 articles. And based on the Bradford Health criteria, our result is considered large because it includes 7 case reports and 1 case series. And our result is consistent because 6 cases showed a possible relationship and 3 cases show a probable relationship. However, in these 6 cases, there are presence of confounder factors, such as patient received valproic acid or propranolol therapy, which are well-known causing the sleepwalking. And regarding the temporality, our results show a chronological relationship because the event is occurred within days to weeks after starting the therapy or after the dose of olanzapine is increased. Regarding the biological gradient, all the cases show a positive D-challenge. So when the dose of olanzapine decreased, this adverse event is disappeared, or when the olanzapine therapy is discontinued, the event is disappear as well. The interesting thing, 1 case show positive D-challenge and positive re-challenge. So when the olanzapine dose increased, the event occurred again. So the possible explanation for this event may be due to olanzapine increase the slow wave by block the serotonin receptor. So it's worth to mention that there are other antipsychotics that are well known to cause the somnambulism adverse events, such as aripiprazole or risperidone. So this event, it's most likely a class effect adverse event. So, as a conclusion, our evidence supports the association between olanzapine and the risk of somnambulism. So we recommend to update the safety information of olanzapine product. Actually, we already did, and we called the companies to update the olanzapine SPC. Thank you.
Sajjal, thank you so much for your presentation. I guess I missed that. What's the possible mechanism behind that side effect?
Yes. Olanzapine may increase the slow wave of sleeping. So this is, we can detect during using the EEG. It's 1 stage of the sleeping stages.
Okay. So yeah, I guess I agree with you. Compared to clozapine and others, they produce a slow wave, while olanzapine, you mentioned, it will increase it. So it could be a possible mechanism through the serotonin. Is there any other possible mechanism you would think about?
Actually, when we did when we did our research, we only found this mechanism.
Okay, thank you so much, سجا. الله يعطيك العافية.
الله يعافيك.
دكتورة هبة. طيب شوف دكتورة هبة إذا ممكن تسأل سؤال.
دكتور محمد. دكتور محمد الشناوي.
دكتور ما أنا شايفة إنه معانا دكتور محمد الشناوي.
هو موجود دكتور محمد.
أنا شايفة باقينا دكتورة مرام. طيب أوكي خلينا نشوف.
دكتورة هبة.
دكتورة هبة عندها technical problem حترجع لنا إن شاء الله.
technical problem.
دكتورة أنا شايفة دكتورة مرام next صحيح؟
دكتور محمد. So let's go next for the next researcher, Dr. Maram Zahrani, for the research entitled Enhancement of the Antifungal Activity of Ketoconazole via the Development of Flexible Lipid-Based Nanoparticles. Dr. Maram.
السلام عليكم ورحمة الله.
عليكم السلام. Can you share your slide?
Yes. You see my slides? It's clear?
Yes.
Yes, clear.
You can start, Dr. Maram.
Assalamu alaikum. I am Maram Zahrani, postgraduate student at King Abdulaziz University, have a master's degree in pharmaceutics. Today I will share some information about my research, my master research. Okay, under supervision of the Prof. Tariq Ahmed. The topic of my research, enhancement of the ketoconazole antifungal activity by the development of the flexible lipid-based nanoparticle. My outlines, introduction.
For the screen.
Is there any problem? I can't hear you.
السكرين تقدرنا تسويها full size.
Okay.
Okay. Now clear.
Okay. First, the aim of the study, the eye infection. The eye infection, it is the most popular problem that facing many people during their life, and the occurrence of the infection, the ocular infection, may be attributed due to different species of fungal. So the ketoconazole, one of the first line in the treatment of the fungal infection, but it is suffer from the lipophilicity in the nature, which impair the giving the low bioavailability and the high molecular weight, which hamper corneal permeation. And the unique structure of the eye has many barriers, physiological barriers, starting from the corneal barrier and the humerus, the vitreous humerus in the eye. The aim of study: enhancing the bioavailability of the ketoconazole to improve the antifungal activity through the eye by developing transoethosomal nanoparticle and formulating in situ ophthalmic in situ gel formulation loaded with the optimized transoethosomal nanoparticle to enhance the ocular formation and to overcome the rapid drug range and the short elimination of the drug in the eye. The transethosomes, as we see, the structure it is contained from three main things: the ethanol and the phospholipid and the edge activator. Experimental part was defined to development of the ketoconazole nanoparticle and the preparation of the ketoconazole transethosomal nanoparticle and the characterization of the prepared formulation and the antifungal activity of the study of the antifungal activity of the ketoconazole nanoparticle and development of the ophthalmic preparation loaded with ketoconazole nanoparticle, characterization of the ophthalmic formulation, then in vitro release study, in vivo ocular irritation study, and vivo permeation study. The development of the transoethosomal nanoparticle loaded with ketoconazole, we using the Draberlin small composite experimental design, and this is design. The aim of using of this design is the development and designing the novel drug delivery system can promising to overcome all the limitation by the conventional topical ocular dosage form. The main four factors, formulating factors that affecting our goal, the drug to phospholipid molar ratio and the percent of the edge activator to the total lipid, and the percent of the ethanol in the hydration media, and the percent of the sterile amine to the total lipid. Our goals: the particle size, minimize the particle size and maximum zeta potential, entrapment efficiency and flexibility. The preparation of the ketoconazole transethosomal nanoparticle by using the thin film hydration lipid hydration technique by we weighing and mixing all the lipid with a specific volume of methanol. Then we subject it to evaporation the organic solvent and form it a dried lipid film on the wall of the flask. Then we hydrate the film with mixtures of ethanol and distilled water, and then subject it to sonication under cool condition for 10 minutes to obtain the transethosomal nanoparticle. And we determine and characterizing the transethosomes, develop the transethosomes, and determine the particle size and the polydispersity index and the zeta potential by using the Mavlon zetasizer and the entrapment efficiency. We calculated the free ketoconazole. The free ketoconazole after subject the transoethosome nanoparticle to indirectly, we calculated indirectly by this equation, but after subjected that the nanoparticle to vigorous centrifugation to participated, and the free drug we can obtain from the supernatant of the formulation. Okay, the flexibility we determine by the extrusion method, and we subject also the physicals we extrude the physicals through the filter paper, and the change in the size before and after extrusion, we can determine the flexibility through this equation. The optimized nanoparticle we obtained showing the size of the physicals 151 nanometer and the zeta potential value positive 34.8 millivolts and the polydispersity index 0.463 and the entrapment efficiency 94.9% and the flexibility 95.4. To identify the effect of the four formulating factor on the four response, we using the multiple regression analysis and we obtain this result and the p-value showing the significant effect on our response by the factor. So the Y1, which represent the size of the physicals affecting by the showing the significant effect with X1 factor and X2 and X3, and the X1 represents the drug to phospholipid molar ratio and X2 to the edge activator, the percent of the edge activator to the total lipid, and the X3 the ethanol in the hydration media. And the Y2, the zeta potential affecting by the percent of the sterile amine in the total lipid. Y3, significant effect by the quadric effect of the ethanol in the hydration media. Y4 represents the flexibility of the trans-etosomal nanoparticle affecting by the percent of the edge activator and the ethanol in the hydration media. It is move or not? Hello?
No, the slide is not moving, and you have 1 minute remain.
The Pareto chart also showing the same things, the factor and the interaction between the factor and the response we studies. And I prepared 8 formulation in situ gel, 6 in situ gel, and 2 from hydrogel, and to compare it, and I make a characterization test for all. And I use two types of the drug. I loaded with trans-ethysomals and the pure drug, and I subjected for characterization. For morphological study, I use the TEM transmission and the TEM showing the particle size smaller than we getting by the light scattering microscope. The antifungal activity showing the superior antifungal activity of the ketoconazole transethysome with inhibition zone 26 nanometer. And in the vivo ocular rotation test, the New Zealand rabbits, 12 New Zealand rabbits we use in the 3 groups, each group 4 rabbits, and we giving the pure formulation with pure formulation without any trans-ethysomal loaded, and we giving the trans-ethysomal load without drug, and the control group. So the trans-ethysomes showing no irritation to no irritant to the rabbit. Conclusion. The trans-ethysomes obtained spherical in the shape with cationic nanosize and high entrapment efficiency and superior antifungal activity also, and which prolong the drug release and no irritation in the eye, and it is able to permeate in deep in the posterior eye segment. And the ketoconazole drug ocular enhancing the formulation will enhance the drug permeation and improving and overcome the short elimination half-life and the rapid drug clearance. Oh, sorry. the obtained result, and this work can be further extended in the future for study the ophthalmic pharmacokinetic and the drug distribution in experimental animal and after ocular application, and we recommend to study the stability of the ketoconazole in the development of optimize the drug ophthalmic formulation. Thank you.
Thank you so much, Maram. Could you go back to the conclusion slide, please?
Yes.
So you're showing here that your formula have a prolonged drug release, no rotation, so all of that advantage. But what about the disadvantage?
The disadvantage
will be like it will cost more nanoparticle. And could you elaborate more about the disadvantage?
I think the stability, it is the main disadvantage, and I recommended to study this is in the future because the nanoparticle needing to special dosage form and special condition for it is for 2 weeks the stability in the lab. So I think it is need to, in this point, need for more study.
Exactly. I was leading to that disability is the biggest issue. Are you planning to do it as a part of your master, or?
No, maybe in the future for the future study. But we work always. I repeated the formulation for each step. I using the fresh formula.
Okay. Why you choose the ketoconazole?
The ketoconazole, it is the most popular, and the limitation, it is not big deal. It is easy to overcome in the lab, but is need to study, need to good formulating step. I think it is not big deal. This is issue, the high molecular weight and high lipophilicity. I think it is can be overcome in the formulation.
Okay, thank you so much, Maram. Allah يعطيك العافية. No further question from my side.
Thank you, Maram. يعطيك العافية. شكرا جزيلا. I have some questions. First of all, going from Dr. Hiba's question regarding why did you choose ketoconazole, comparing the price-wise, if we're going to talk about the process of making the nanoparticles of ketoconazole to any other antifungal that it's available in the market, how do you see it? Is it really cost effective to do the
formulation
nanoparticles for the ketoconazole, or any other antifungal that it is more effective?
I think it is. Yes, I think it is a good formulation, and it is show more penetration. And the no formula for ketoconazole applying ocular and topical. It is all the formulation using ketoconazole. It is topical through the transdermal, and the ocular we using in this is technique for the ocular application. It is a new technique to using to apply this drug, and this is route of administration. It is a new one, no previous study. Applying the another in the same group, but is with other techniques, and it is different in the disadvantage and characterization between.
Okay, thank you, Maram. My last question: did you do this research by yourself?
Yes.
This is one of the rare researches that I find just only one name in it. So you are doing it purely by yourself?
Yes. I do by myself with some يعني helping in the animal study but within the team يعني in the animal study but in the college, in the same college.
Yeah. Murad, correct me. Is this your master? صح?
Yes,
Master.
yes. Master thesis.
Master thesis. Thank you.
شكرا جزيلا. شكرا. أنا completed. Thank you.
Thank you, Dr. Maran, for your great presentation. Now we'll go for the next researcher, Dr. Rafal Ghatani, for the research entitled Antivascular Endothelial Growth Factor Nanoparticles for the Treatment of Diabetic Retinopathy. Dr. Rafal?
Yes.
Can you share your slide? Can you share your slide?
Can you see my slides?
Yes.
Okay.
Just full the screen.
Now?
Yes, yes.
Okay.
Clear. You can start now. Thank you.
Okay. Assalamu alaikum wa rahmatullahi wa barakatuh. Good afternoon, everyone. My name is Rafal Ghatani. I'm a master candidate in the Department of Pharmaceutics, King Saud University, and I'm a teaching assistant at Al Marifa University for Science and Technology. I'm here with you today to present a part of my project entitled Antivascular Endothelial Growth Factor Nanoparticles for Treatment of Diabetic Retinopathy. This project is under supervision of Dr. Fadil Al-Anazi, Prof. Ibrahim Sarra, and Dr. Rafal Ghatani. These are my outlines. First, I will give you a brief introduction about this project, as well as objective, methods, results, conclusions, and references. For the introduction part, first I will talk about diabetic retinopathy. It is a well-known consequence of diabetes mellitus. It affects lots of diabetic patients. It is prevalent in more than 35% of diabetic patients, and it is a disease that causes damage to the retina as a result of hyperglycemia. So this is a picture of a normal retina. The retina is a very fine layer lining the back of the eye and responsible for initiating the process of vision. Diabetic retinopathy is categorized into non-proliferative diabetic retinopathy and proliferative diabetic retinopathy. If non-proliferative diabetic retinopathy is left untreated, it may evolve to proliferative diabetic retinopathy, which is characterized by vitreous hemorrhage and retinal detachment, which may lead to complete blindness of diabetic patients. Anti-VEGF therapy has been recently adopted as a new treatment modality for diabetic retinopathy. Riboxystorin is a new investigational drug that is an anti-VEGF drug, which is still under clinical evaluation, but proved to be very effective in slowing down or even prevent the progression of diabetic retinopathy. As I said, this drug is an investigational drug, so upon the approval of FDA, it will be available in a form of powder and need to be delivered to the retina in a suitable drug delivery system. Among present drug delivery systems, nanoparticles as drug carriers have shown a great potential in recent years. Scientists now are shifting to nanoparticles as drug delivery systems, since that is why nanoparticles can overcome lots of problems or complications associated with conventional drug delivery systems. These include burst release of drugs, severe complications, and non-specificity. We have examples of nanoparticles such as liposomes, cubosomes, nanoemulsions, and dendrimers. Dendrimers have recently proved themselves as a bioavailability, solubility, and permeability enhancers. In specific, polyamidoamine dendrimers, or we can call it PAMAM dendrimers, have recently got an enormous attention owing to their distinctive architecture and unique properties. So this is a PAMAM dendrimer showing its internal cavities. It is composed of a core and a number of added shells, or we can call it generation. And as the number of generation increases, the diameter of the particle increases. PAMAM dendrimers have many unique properties, such as monodispersity. They are safe and non-immunogenic nanoparticles that are biodegradable with a large surface of area that make it capable of encapsulating a large number of drug molecules. They also enhances the bioavailability of drugs, provide a targeted drug delivery, sustained delivery of drugs to give better therapeutic outcomes. So because of the unique properties of PAMAM and its unique structure, we aim to formulate riboxystorin nanoparticles using polyamidoamine dendrimers. So this is our objective, to develop riboxystorin nanoparticles using PAMAM dendrimers generation 5 for treating diabetic retinopathy. So to achieve our objective, we have implemented several methodologies, including first, the formulation of the proposed nanoparticles. Different amounts of riboxystorin were added to PAMAM's generation 5 and different riboxystorin to PAMAM molar ratios. Next, a ratio of 1:1, 2.5:1, and 5:1 riboxystorin to PAMAMs were stirred overnight at 4 Celsius to allow the encapsulation of riboxystorin within PAMAMs. Second, the in vitro analysis. After formulating the proposed nanoformulations, we performed the in vitro analysis. We have assessed the drug loading concentrations and encapsulation efficiency. As well, we determined the particle size of the proposed nanoparticles, polydispersity index, and zeta potential. As well, the in vitro release studies were performed on the proposed nanoparticles. And as well, the morphology and the encapsulation visual pattern was determined using transmission electron microscopy. So these are my results. For the encapsulation efficiency, we found out that all the proposed nanoformulations has a very high encapsulation efficiency. For the drug loading capacity, as we can see, complex 1:1, 2.5:1, and 5:1 possessed a drug loading concentrations of 1.6, 4%, and 7.1% respectively. As we can see from these results, we can find that generation 5 complex 5:1 possessed the highest measurements. So for the polydispersity index, zeta potential, and particle size, we have assessed the polydispersity index first for the empty dendrimers and then for the proposed ones. As we can see, there is no change between the empty and loaded PAMAMs, which indicate a very good monodispersity of these nanoparticles. For the zeta potential, as we can see, we measured the surface charge of the empty PAMAMs and as well the loaded ones. And as we can see from the results, there's no big changes in the surface charge, which indicate a good stability of the proposed nanoparticles. For the particle size, we measured the empty PAMAMs and also the loaded PAMAMs. As we can see here in the empty PAMAMs, it revealed that the particle size is 214.9, and it increases dramatically after the encapsulation process as a result of the complex interaction between the PAMAM dendrimers and riboxystorin. So this is the in vitro release studies. We have performed it on all the proposed nanoparticles, and they all revealed a sustained release of the drug. As we can see here, a generation 5 complex 5-to-1 revealed the highest release rate among all other studied nanoparticles. In addition, we have determined the morphology and the assessment, the encapsulation pattern of PAMAM dendrimers. Here are the empty PAMAM dendrimers. This is a picture under transmission electron microscopy. And we can see here the PAMAM dendrimers loaded, clearly loaded with riboxystorin. So these are our conclusions. Further in vitro studies are warranted to develop riboxystorin nanoparticles using polyamidoamine dendrimers. This nanoformulation will improve the therapeutic outcomes of anti-VEGF therapy and the bioavailability of riboxystorin to prevent vision loss in patients with diabetic retinopathy. These are my references. Thank you so much for listening to my presentation. Any questions? Hello?
Thank you so much for your presentation. I have a couple of questions. Are you planning to do any vivo study?
I cannot hear you well. What? Planning?
Sorry.
Yes, doctor.
You mentioned the Vitro study.
Yes.
Planning to do.
Yes.
Can you elaborate more? And are you planning to do any vivo study?
Okay. So actually, my in vitro studies are not yet completed. I want also to assess the stability for a long time for the nanoparticles, and I am working on it right now. Also, I have, I also have in my research cell line, I will use Muller cells. Yes, so this is the future plan.
Okay. I agree with you that nanoparticle-based drug delivery is the way to go and to treat lots of diseases, for sure. I wish if you have more, more results to share with us. You mentioned that there is a lot of different method to develop the nanoparticle. Why you choose this one compared to other? What's the advantage?
You mean why did I choose the PAMAM dendrimers?
PAMAM, yeah. Compared
Okay.
to the
Okay, let me just go back to the slide. Okay.
I think it's in the beginning.
Actually, it is because of the unique properties and distinctive architecture. As you can see, it is a hyperbranched molecule, so it is able to encapsulate a very high number of drug molecules, and not even encapsulation. It also can conjugate with drugs on its surface. So it is a very high capacity. Also, it provides targeted drug delivery. That is why we choose this type of polymer.
Doctora, can you repeat the last part? Just your voice cutting.
Okay. Yes, as you can see, it is a high
targeted drug delivery, but I would assume it will be more challenge and costly compared to the other. دكتور محمد يمكن أنا عندي مشكلة في do you wanna...
Yes, doctor, I'm with you now.
Even I did not hear any answer.
هذا دكتور محمد do you wanna...
Doctor, can you hear me now?
Yes, go ahead.
Yes, okay. Can I just get back to the slide?
Yes, please.
Okay.
Doctor, we can't hear anything.
Even the slide got frozen.
دكتورة رحاب, can you hear us?
Hello.
طيب دكتور محمد,
دكتورة
if you
رحاب,
have
can you check your connection?
Dr. Rehab, can you hear me? Can I ask the question or you cannot?
So we'll go for due to technical issue. We'll go for the next researchers, Dr. Fawaz Faqiha, with research entitled "The Potential Chemosensitizing Effect of Potassium Para-aminobenzoate on transplant tumor model treated with 5-FU." Dr. Fawaz.
Assalamu alaikum. Me?
Alaikum assalam. Can you share your slide?
Yes, I would. Yes, couple of minutes. Can you see it now?
Yes.
Can you see the slide? Yes.
You can
Could I
start.
start, please?
Yes, yes. كبر
السلام
السكرين full size please.
Okay. مو طالع الحين فول سايز انه انا مسويه فول سايز ما نعرف. هل هي واضحه الحين فول سايز؟
No, not yet. من فوق دكتور على اليسار سوي فول سايز.
اوكي.
صح؟ او F5.
اوكي F5 سوري. F5 ممكن بس مشكلة كذا تمام؟ المشكلة ما هو طالع عندي الباوربوينت فماني عارف اسف.
خلاص we'll share from our side. Okay, wait a second.
Okay, yes, I appreciate it. Please.
Yes, clear now. You can start now.
Okay. Assalamu alaikum wa barakatuh. Good afternoon, everyone. First, let me introduce myself. My name is Fawaz Faqih. I am Pharmacy College of Pharmacy in Taif University. I am doing this research with the collaboration with the Dr. Ahmed Qabil. Just wanna excuse for what happened for a while, maybe a technical problem. Our topic today is the potential chemosensitizing effect of potassium para-aminobenzoate on transplantable tumor model treated with 5-fluorouracil. Potassium para-aminobenzoate, it's also called POTABA. It's a form of vitamin B. And transplantable, that means something I can take it cancer cells from site to another site and easy to inject it. This picture I will back to mice. Okay. The background: cancer is characterized by unregulated cell growth, as we know. The anti-cancer agent, which is here 5-fluorouracil, may cause harmful adverse effect. So, to decrease the dose and side effect, we use safe agent, which is with anti-cancer properties in combination with anti-cancer agent is essential. 5-fluorouracil, our anti-cancer agent, is an antioblastic agent that treated solid tumor. Its effect may be complicated by dose-dependent adverse effect, and we want to minimizing the 5-fluoro dose-effective dependent. We search for a safe agent. Our safe agent here, it's Butaba, or potassium paraaminobenzoate, which is form of vitamin B, support many of body function. And the recent study said Butaba may have antioxidant and anti-inflammatory effect. And this is why we use it, because as we know, the patient with the cancer, has a very oxidant and inflammation, and something would make it antioxidant and anti-inflammation that maybe help us as a safe agent. So the aim of our study to detect the possible chemosensitizing effect of potassium on transplantable tumor model treated with 5-fluorouracil. Material and method. Solid Ehrlich carcinoma, which in our research we bring it from King Fahd Center in King Abdulaziz in Jeddah University. Solid Ehrlich carcinoma was injected subcutaneous into the right thigh in mice, and the palpable solid tumor mass will develop within 2 weeks. We used 50 male of bulbous mice were divided into 5 equal groups. In this picture, just to see the left one of the mice, the enlargement in his right thigh, as we see, this is injected subcutaneous by solid Ehrlich carcinoma, and the right one, which is the control. The picture right, the solid when we excreted from the mice. A palpable solid tumor, what that mean? Palpable, that means something I can touch, can feel it. So now when I can recognize the cells enlargement, and we said we have a cancer. After that, when we see the palpable tumor, we divided our bulbous mice into 5 groups. First one control, just to compare with another one. Second one only our disease, which is solid Ehrlich carcinoma. After that, solid Ehrlich carcinoma and 5-fluorouracil, which is anti-cancer agent. After that, we use Butaba, which is I just wanted to make sure if it has anti-inflammatory and antioxidant or not. And the final, we made the combination between Butaba and 5-fluorouracil. The tumor volume were recorded every 5 days by Fenner caliber. And the end of the study, all mice were killed and the tumor was exist. Why we kill all mice? Because in the mice, after 40 days, it's dead and the tumor become analysis. And this has happened to me, to be honest, with my uncle, Allah yarhamah. He has colon cancer, and the day when he was dead, he be very normal. And he come to ask me about my father, and he said, I want to go to bathroom, azakumullah. After that, somehow, with a couple of hours, he's dead. Also here, when we're doing this is research, the 50 male of bulbous CC, it's die after 40 days. I was very happy. I think there is no tumor because he can move. After that, somehow he's dead. So we're doing this again, and before 40 days, we kill all tumor by ethical way, and when we kill all mice, it succeeded the tumor to see histopathological and biochemical enzymes. The catalase and the tumor necrosis factor alpha were measured in the tumor tissue, because catalase, if we have more catalase, that mean more antioxidant, and tumor necrosis alpha, if we have, that mean inflammation. After that, a study approved by research ethics community in Taiwan University. That was very important before start the research. And we using statistical analysis was carried out by using SPSS version 21. This is our result. Just please focus with me. As we see, control in the same line of the 0. There is no tumor because patient control, or no cancer. There will be any tumor. After that, the black one, which is the highest, it is our disease alone. As we see here, it's there is tumor. very much by other group. The green one, we use Butaba and solid Ehrlich carcinoma alone. As we see here, there is difference between solid Ehrlich carcinoma alone and with our safe agent alone, which is a Butaba. The red one, we use solid Ehrlich carcinoma and anti-cancer agent, which is 5-fluorouracil. We see it's better than our safe agent. But the combination between 5-fluorouracil, which is the pink one, and Butaba is significant improve better than each drugs alone. After that, as we see here, another result for tumor tissue catalysis control and A, solid Ehrlich carcinoma, B, solid Ehrlich carcinoma with 5-fluorouracil also, and another one with Butaba. As we see here, there is significant for 5-fluorouracil and Butaba, but combination was better and look like closely from the control one. Then we use tissue necrosis factor alpha. The control one, as we see here, there is no inflammation or inflammation just not too much, but solid Ehrlich carcinoma alone it's high, but combination was better, as we see here in the BCD, which means combination potassium para-aminobenzoic acid with 5-fluorouracil. Now I will talk the histopathological examination, as we see here. The A control also, B only the disease solid Ehrlich carcinoma, C the solid Ehrlich carcinoma and 5-fluorouracil, D with Butaba only and solid Ehrlich carcinoma in the combination. As we see here, the A and B and C. Let me talk about B, the solid Ehrlich carcinoma. There is a sheet of line of carcinoma or malignant cells. It was blue here or hypochromic. And see the pink one, necrosis cells. Necrosis cell, that means can kill the malignant cells. As we see here, the arrow. D, it's also better than B, which is I want compared between the our disease, which is solid Ehrlich carcinoma. And if you see the A, there is too many pink more than the blue one or hypochromic, which is malignant cells, and that means improve significant in the combination, better than each drug alone. Conclusion of our study: Butaba has chemosensitizing effect against solid tumor treated 5-fluorouracil in mice, which may present a new hope for cancer chemotherapy. Further study are needed to explore possible clinical implementation for 5-fluorouracil with Butaba in combination. And we want to try doing this research, inshallah, for nanoparticles, inshallah. Also, maybe question why I use Butaba, because one of the important things, it's inhibit glycoprotein, and we know glycoprotein exists the drug outside the cells. But when we inhibit glycoprotein, which can doing that Butaba, that means it is the drug will be in cells more time. That means more effect, inshallah. This was end of my poster. I hope you enjoy it and simple, and thank you for listening. There is any question?
Fawaz, Allah يعطيك العافية for this amazing presentation. I have a couple of questions for you. One, the dose of Butaba. And number two, you show a reduction, but was it statistical significant or not? Can you elaborate on that as well, please?
Okay, Butaba I used 200 milligram per kg, and this is a vitamin. The recent study was giving 200 milligram per kg for Butaba. And significant, yes, we're doing that, as I say, in ANOVA, and the p-value was less than 0.5, which is significant.
Okay. Are you planning to test another dose?
I look, to be honest with you, and this research, I doing too many doses and too many things, but this was the best one. So I put it in the poster because I want to give as a poster the best information only.
Sure. So basically, you test like let's say 3 to 4 doses, and you pick the The best.
The best one, yes.
The best of them. Okay, great. That's all. And could you elaborate more about the mechanism behind this interaction between butapa and 5-fluorouracil? You mentioned it in the beginning. Can you elaborate more?
Yeah, not as I said, interaction was no, synergistic effect was better.
Synergistic effect, yeah.
Yeah, because butapa, if you read it about the uses for skin problem, and chemotherapy may cause skin problem, you know. For when I put together, will be less dose and more effect and less side effect, because one each help other thing.
Okay. Thank you so much.
Thank you.
فواز يعطيك العافية.
الله يعافيك.
صراحة جدا يعني مجهود رائع. I have one question.
Okay.
What is the possible side effects that you can predict from such combination?
Look, for general, because vitamin, it's analysis in the liver and also chemotherapy, maybe hepatotoxicity. I think it will be if there is no dose management and not giving by the right way, because 5-fluorouracil again has hepatotoxicity, and also vitamin, it's in our body, it's responsible for hydrolysis of the liver. If we don't give by good way or high dose, I think it will be a problem in the liver.
So in such patients, you expect the liver that it will be functioning very well?
Not patient, I use in mice, and so was
yes.
Yes,
no, for example, future, our target is to be used in vivo in patients. Yeah. So if you will use it, for example, with breast and prostate and gastric cancer,
okay,
is this gonna help at the end?
Look, I can't say will help or will not, only the God can judge, but all what I said, inshallah, because in solid tumor and in mice, it was very good. And if we want to use it with patient with the hepatotoxicity, if was the only choice, I will do it, and with dose management like another treatment.
Okay, thank you.
Thank you.
Thank you, Dr. Fawaz, for your great presentation. Next, we'll go for the next researcher, Dr. Kauthar, with research entitled The Evaluation of Antimicrobial Effects of Expired Oral Antibiotics in Vitro Study. Dr. Kauthar?
Yes.
So can you share your screen? Yes, it's clear.
Me? You can see the slide now, right?
Not yet. Can you? Yes, now it's, I think, clear.
Okay. So, hello everyone. My name is Kauthar, and I'm master candidate in radiopharmaceutical science. And I will present my research project today, which is about evaluation of the antimicrobial effect of expired oral antibiotics in vitro study. So let's start with the background. Drug expiration date, which is mostly 2 to 3 years after the drug is manufactured, except in some the specific date until which the medication will be effective, if stored under a proper condition of light, temperature, and moisture. But if not stored under a suggested condition, the medication may lose potency even before the expiration date. Whereas in spite of warnings that medication that have passed their expiration can pose significant risk, and that's extremely important to properly dispose of expired medication to avoid serious injuries to older adults and children. Not all scientists that still agree that expired medication are unsafe. It has been reported that many drugs stored under reasonable conditions retain 90% of their potency for at least 5 years, and sometimes much longer after the expiration date on the label. Some studies provided preliminary microbiological results on the appreciable reduction in vitro bacteriostatic potential, as well as higher resistant and multiple antibiotic resistant, reach among expired oral antibiotics a point from less efficacy. Administration of expired antibiotics can lead to increased antibiotic resistance and clinical failure as well as adverse drug reaction. So our aim is to investigate the effectiveness of expired oral antibiotics in bacteriostatic. So our method is we take 5 different classes of antibiotic. We take clarithromycin, levofloxacillin, chloxacillin, and tetracycline. And we take Staphylococcus aureus bacteria to work with it because it works with the gram-positive bacteria. Our study is done by disc diffusion technique. This technique takes agar and culture with the bacteria and then apply this, take agar and culture and then apply the disc of antibiotic. As you can see, this two disc azithromycin, and this is the zone of the disc of antibiotic, and this is the zone of antibiotic. This is the zone of disc antibiotic, and this is the zone which antibiotic kills the bacteria. The zone of inhibition of control is bigger than the expired one, but the expired one is still in the range, and it is susceptible. Our result shows that this is the zone of inhibition of which we take it, and this is the zone of inhibition of expired oral antibiotic, all in the range and all susceptible. As you can see, there is no difference between the clarithromycin, the expired one, and the control one, and also the tetracycline. And the diameter of inhibition zone lies within susceptible range. The p-value was 0.57. This figure shows the expired and unexpired oral antibiotics. The difference between them, as you can see, the blue one is the unexpired and the red one is the expired. The blue one is higher than the red one, but the red one is still in the range, and it is susceptible according to the National Committee Laboratory Standard. This figure shows the expired and control azithromycin in suspension dosage form. We choose the suspension dosage form because it's less stable than solid dosage form and less expensive. As you can see, the blue one is the control and the red one is expired. The blue one is higher than the red one, but the red one is still in the range, and there is no difference according to the p-value, and the p-value was very small. In conclusion, we could say that many drug products may have extended shelf life beyond their expiration date, and it's difficult for a healthcare provider to know which product could have extended shelf life. Our recommendation is that we can use expire antibiotics until 3 years of expiration, but in development country we cannot use it because there is a possibility of exposure to heat and humidity, and we can use expire oral antibiotic if the control is not available. For example, some poor country, they cannot afford the new antibiotic, but they can use the expired antibiotic. This is a take-home message. Each time we take an antibiotic, we increase the chances that bacteria in our body will be able to resist them. And when we take the antibiotic, to follow the direction carefully, it's important to finish the medication course even if we feel better. Here is my references, and thank you for listening.
دكتورة مي.
The floor is yours. تفضل دكتور محمد. I will follow you.
شكرا جزيلا. Thank you, دكتورة كوثر, for this great presentation. I have a question regarding the expired selection. expired after how many days or how many months or how many years that you took?
Actually, we took not a specific date, but a different year. For example, for 2014, 2013, and 15, because we find difficulty to find the expired medication, and not everyone can give us the medication in a specific year.
Because I believe this is a very important thing. If you're going to choose, for example, a shelf life of any medication or any antibiotic for 2 years, and if I take it after 1 year from its expiry, this is 50% from its shelf life. So 1 year or depend on. Maybe my last, it's not a question, it might be a comment that your recommendation should be taken into consideration very carefully. Do not, we cannot go in any research and recommend if any antibiotic is needed, it can be used. I believe this is, and from my perspective, it's very dangerous to put it as a recommendation. However, that we can deal with the legal authorities at any country in order to have this kept in their consideration. And I believe our Saudi FDA, they are following such thing and they are putting recommendations. Thank you from my side, Dr. Hiba, Dr. May.
Dr. Muhammad, thank you so much. Exactly the same point. With the method, the biggest issue was the defining the expiry or you mentioned expiration date. This is a big issue. If we go back to your recommendation, can you go back to the last slide? Take home message, I guess. Slide up, yeah. So you say you're mentioning the resistant, and that we have to take specifically. This is an issue with antibiotic, and we have to take it as it's intended. Don't you think that recommending to take an antibiotic that is expired and we're not sure effectiveness, that might increase or add to the problem of antibiotic resistant?
Regarding to the research paper, we didn't find as a big issue and as a side effect regarding that. And I believe that we need more research need to be done in this area, especially in rats and human, to make sure that's safe and people can take it.
Doctor, and my other question: why antibiotic? Why not خلينا نقول analgesic? What's the rationale behind choosing the antibiotic?
Actually, I think because this is a big issue in our area, and especially Saudi Arabia, as they put a guideline that not any pharmacist can dispense the antibiotic without a prescription. And
No, I mean, doctor, you choose to study the expired antibiotic.
Yes.
Why it's not the expired analgesic مثلا? Why specifically the antibiotic? What's the rationale behind that?
It's a new era of antibiotic, because I didn't see much research in this antibiotic here. It's hard to find the antibiotic as an expiration to do the research on that. Especially when we are also looking for the paper, we didn't see much paper on that. So we find it's interesting to do it in antibiotics.
I suggest to follow a recommendation of Dr. Muhammad and reconsider the method. But thank you so much for your presentation. I really appreciate your time. Thank you.
Thank you.
Thank you, Dr. Kawthar, for your great presentations. Finally, the last researcher is Dr. Hassa Ghatani, with research entitled The Superinfection Rates Among the Patients Treated with Carbapenem versus Tazocin, a retrospective observational study. So, due to technical issue with Dr. Hassa, we'll use a different approach in utilizing this virtual meeting through the phone. So, if there is anything unclear, please confirm with us.
اوكي كده الصوت واضح؟
Yes, clear.
Okay. Good afternoon, everyone. I am Hassan Ghatani, a pharmacist in King Abdulaziz Medical City. I'm so glad to present my research result in the first pharmacy research day. My research project entitled Superinfection Rate Among the Patients Treated with Carbapenem versus Piperacillin Tazobactam, retrospective observational study. My outline going to be next slide. Background and objectives of my research, then methodology, then discuss our findings, finally conclusion of our result. As introduction for this research, the superinfection is a new isolated pathogen which is the other than the initial pathogen. After 48 hours of antibiotic treatment or within 1 week of treatment discontinuation. The isolation of a bacteria strain different to those causing the primary infection, which may require additional antibiotic intervention. In general, broad-spectrum antibiotic therapy as compared to the narrow-spectrum antibiotics associated with higher risk of superinfection, and monotherapy treatment was associated with a lower number of superinfection. And we found in many studies that carbapenem and piperacillin tazobactam was associated with the high risk of superinfection. So the aim of this research was to evaluate the rate of superinfections during carbapenem and piperacillin tazobactam treatment. In addition, to identify the most risk factor for superinfection, also to identify the most common pathogen causing superinfection. Now moving to the methodology. This is a retrospective observational study was conducted in King Abdulaziz Medical City, Central Region, over 1 year, from January 2018 to December 2018. This study was approved by Ethics Committee of King Abdullah International Medical Research Center in January 2019. This study includes all adult patients aged more than 18 years old with infections and treated with either piperacillin tazobactam or carbapenem, either meropenem or imipenem, for more than 72 hours. And we exclude who had received the antibiotics for less than 72 hours or whose infection had no clear source. In statistical analysis, first a series of tests were conducted to explore the association between each independent variable and the dependent variable. After that, all significant variables in the univariate analysis were included in the final multivariate logistic regression used to compare the association between different independent variables and development of superinfection. We retrospectively reviewed the medical record of 507 patients. Sorry, the previous slide. Okay. We retrospectively reviewed the medical record of 507 patients who received either carbapenem and piperacillin tazobactam. Of these, the result of these 200. Next slide. Of these, 278 patients received carbapenem, either meropenem or imipenem, and 229 patients received piperacillin tazobactam. Our data shows that of these patients, 128 patients were developed superinfection, which is about 25%. Based on our findings, the frequency of sober infection was 28% in carbapenem group and 21% in 20% in piperacillin tazobactam group. Over the duration of treatment with p-value 0.04. So carbapenem was associated with higher rate of sober infection than piperacillin tazobactam. This is in univariate analysis, but after adjustment of co-founder in multivariate analysis, it became not significant with odds ratio of 1.05. And the other factors increase the risk of sober infection where duration of antibiotic present of endotracheal ventilation and tracheotomy, present of a central venous catheter and present of Foley catheter, and patient received proton pump inhibitors and length of hospital stay. But when these factors were analyzed by multivariate logistic regression analysis, it was found that only 4 variables were statistically significant risk factor associated with development of sober infection. As listed here, tracheostomy with odds ratio of 3.2, which is significant, and endotracheal ventilation also present of Foley catheter with odds ratio 2.2, and the duration of antibiotics with odds ratio 1.05. We found each day of antibiotic use was associated with 5% increase the risk of sober infection. According to our result, the main isolated microorganism after 48 hours, as can we see here, about 53% of all sober infection was candida. It was 68 events. Then Staphylococcus and Pseudomonas aeruginosa about 11%. And C. diff was only 7% of all sober infection, only 9 cases. In one meta-analysis showed that carbapenem was associated with more than 5-fold increase in C. diff infection compared with the use of no antibiotic, but high rate of C. diff infection with carbapenem wasn't seen in our study. Maybe the reason behind this is the international and national data disagreed in regard to C. diff infection, lower national data of C. diff compared with international data. So maybe this is the reason. As conclusion of this research project, the rate of sober infection following carbapenem and piperacillin tazobactam in hospitalized patients was common, but not statistically significant difference between carbapenem and piperacillin tazobactam treatment. Also, the most risk factor associated with sober infection were longer duration of antibiotic, present of polycatheter and endotracheal ventilation, and tracheostomy. Also, the most present pathogen was Candida. Thank you.
I have a very quick question. Since this morning and maybe yesterday as well, a lot of researches were conducted on carbapenems. Why you choose carbapenems? Who guided you to this?
Because we find a lot of study.
Yes, go ahead, please.
Yeah, because we can find a card. Because we find a lot of study reports in.
صوتك اختفى.
حصة في time lag ما قاعدين نسمع.
Because we found in many studies that carbapenem and piperacillin associated with the high risk of sober infection.
I mean, حصة دكتور محمد, if you allow me.
تفضلي.
He's asking, usually we do research when we find a gap in our knowledge. If it's already covered, as you mentioned, in the publication, why repeat it? And if
The aim of this study to compare carbapenem and piperacin tazobactam.
انا صراحه حاسس انه منصه تيم تعبت من اول الصباح ومن امس كمان شغاله، فيعني يمكن شويه حصل فيه ديلي او على يعني last presentation it got يعني there is a lot of delay او ماني سامع الصوت صراحه. يعني انا this is from my side.
I agree with you, Dr. Muhammad. Hassa, do you want to add anything?
دكتورة حصة.
Yes.
Dr. Hassa, do you want to add anything? Dr. Hassa, do you want to add anything or ask the judges for anything?
No, thanks.
Dr. May, do you have any question for Hassa? We can tell her that question.
No, thank you so much. We really appreciate Hassa and the others. I just want to stress on when you think about research, always think about the impact of your research on impact. Impact is the most important thing. Thank you so much.
You mean the impact on the current practice? Dr. May, point that what will your research add to the current evidence? Thank you very much, Dr. May. Dr. Shenawi, do you have anything to add to Hassa?
Thank you very much.
Appreciate it, Dr. Shenawi.
Thank you, everybody, for being with us for the whole day. Just give us a couple of minutes to calculate the scores and announce the winners, please. شكرا دكتورة مي، شكرا دكتور الشناوي، أبدعتوا صراحة وشاركتوا، والله يعطيكم العافية على التقييم والتحكيم الجيد. شكرا لكم. السلام عليكم.
وعليكم السلام دكتورة. الصوت واضح دكتورة؟
صوت واضح؟
ممتاز.
شكرا لك دكتورة. طيب الحمد لله وصلنا بفضل الله ومنته علينا وعليكم جميعا إلى نهاية اليوم الثاني من الفارماسي ريسيرش داي، الفيرتشوال فارماسي ريسيرش داي at National Guard. We reached the end of our event, which was really unique and distinguished with the presence of the keynote speakers, researchers from different specialties, and our experienced judges. We are very optimistic, actually, that the outcome of this meeting will shed a light on all pharmacy sectors and specialty, if you do agree with me. And I think even the people who did not win yesterday, the researcher, they have a very good experience, and definitely they will get benefit from all the comments and questions that they received from the judges. Same thing as for the group today. Would you please allow me to announce the names of the elite group for today? And actually we have 5 winners. The discussion and the session today was very active, to be honest with you. And everybody here in the command center were very enthusiastic for the researchers and waiting for the judges to send their scores. And we'll start announcing the names, starting with the 5th winner. The winner number 5 is Dr. Fawaz Faqih from Taif University for his project, The Potential Chemosensitizing Effect of Potassium Para-aminobenzoate on Transplantable Tumor Model treated with 5-fluorouracil. So مبروك دكتور فواز والله ينفع بك ويقر عين والديك فيك يا رب. The 4th winner is Dr. Selwa Sahibani. Dr. Selwa, she presented the effect of sacubitril valsartan on glycemic control in heart failure patients with diabetes. Dr. Selwa, she's a distinguished resident from Princeton Cardiac Center. مبروك دكتورة سلوى. Our 3rd winner. The 3rd winner is Dr. Nada Al-Saleh for her excellent project. And it's the only unique project in these 2 days that discuss a quantitative research. We really enjoyed it, and good luck for you, Dr. Nada, for your project titled with Exploring Physician Views, Perceptions, and Experience about broad-spectrum antimicrobial prescribing in a tertiary care hospital qualitative approach. Very good job. Well done. The second winner is Dr. Rawan Swalim for her project entitled MicroRNA-loaded Chison Nanoparticles for Treatment of Glioblastoma. Actually, Dr. Rawan, you impressed the judges, Dr. Hiba and Dr. May, and very good job. Thank you very much. Now let's go for the first winner for today. Would like to congratulate Dr. Afaf Dahish from King Khalid University for being the first winner for today and having 100% score for her presentation from both judges, Dr. May and Dr. Hiba. Dr. Afaf presented a topic on calcitonin-induced stem cell-like phenotype in prostate cancer cell. ألف مبروك لجميع الفائزين، بل وألف مبروك لكل المتحدثين اليوم. أعتبر الجميع فائز معنا اليوم، وأعتقد كل الكومنتس والمداخلات اللي حصلت مفيدة للجميع، وتمنياتنا لكم بالتوفيق والله يرفع قدركم. ونشوفكم إن شاء الله في إيفنتس قادمة بإذن الله. السلام عليكم.